I'm going to talk to you today about resident memory T cells, which is definitely an emerging concept in dermatology. And if you haven't heard about resident memory T cells in your field, I will bet that over the next few years you will be hearing a lot more about them. And hopefully you'll see why by the end of this talk. The learning objectives for this morning are first to define resident memory T cells and discuss how resident memory T cells in the skin are generated. Then we'll discuss the role of resident memory T cells in cutaneous disease and the implications for treatment. And finally, we'll discuss resident memory T cells as a general human barrier defense strategy and their potential role in numerous chronic diseases, as well as their potential role in improving vaccination. So let's start with the first objective, and I believe I'm the only dermatologist, so I want to just frame this presentation by reminding you about some basic facts concerning the skin. As all of you know, the skin is the largest organ in the body, and it represents the primary interface between us and the environment, and therefore it must be able to provide first-line defense against all the potential pathogens in the environment, as well as physical and chemical insults. So it should come as no surprise that the skin is very rich in immunologic activity. And because of its accessibility, over the decades it has been a popular model system for studying human immunology. And there have been some important breakthroughs in our understanding of human immunology by focusing on the skin. And one of those was the concept of the skin-associated lymphoid tissue. This was described first in 1983, and it introduced this idea of the immune system in the skin being dynamic, and immune system cells circulating between the skin, the lymph nodes, and the blood continuously in order to provide optimal immunosurveillance, but also allowing mobilization of cells to a specific area that was under attack when needed. And through the years, this became known simply as the skin immune system. And there are many different cell types that participate in the immune system and provide functions that are critical to its optimal functioning. And of course, one of the most important cell types in the skin immune system is the T cell. A normal, healthy skin contains nearly 20 billion T cells, and that's more than double the number of T cells in the entire blood volume at any one time. And most of these cells are memory cells, with CD4 positive and CD8 positive T cells being present in equal numbers. And just to remind you about a memory T cell, an individual memory T cell will recognize a specific antigen that the host has been exposed to in the past. And as an entire population in any individual, memory T cells can recognize a very wide variety of antigens, from pathogens to tumors to environmental substances. And these memory T cells are able to provide very rapid and highly effective protective immunity against things that the host has been previously exposed to. In other words, they provide immunity that is the hallmark of adaptive immune memory. And it was previously thought that memory cells consisted mainly of two major subtypes: central memory T cells and effector memory T cells. Central memory T cells, by and large, traffic between the blood and the lymph nodes, and they're characterized by expression of the chemokine receptor CCR7 and L-selectin, or CD62L. And those cell surface markers grant central memory cells access to the lymph nodes from the blood. Effector memory T cells, on the other hand, mainly traffic between the peripheral tissue, in our case the skin, and the secondary lymphoid organs, the lymph nodes. And although they express low levels of CCR7 and CD62L, they express other cell surface markers. So in the case of the skin, they express cutaneous lymphocyte antigen, or CLA, and that grants these cells access to the skin. But within about the past 10 years or so, it has become clear that there's another important subset of memory T cells, and that is the tissue-resident memory T cell. These cells were described as early as 2001, and these are cells that literally reside in a peripheral tissue. They are characterized by their inability to leave the peripheral tissue, the skin, and travel back into the lymph nodes in the blood. And it turns out that in the skin, resident memory T cells are enriched for pathogens and antigens that have been encountered previously through the skin. So these cells are strategically placed there to protect the skin barrier against things that have been known to try to penetrate the skin and invade the host. It's a strategy that seems very worthwhile contributing energy towards. So let's talk about how skin-resident memory T cells are generated. During an infectious challenge, dendritic cells are the first cells to see the pathogen, and they take pathogen fragments back to a draining lymph node and present antigen to naive T cells. And when a naive T cell recognizes that antigen, it becomes activated and clonally expands, with one naive T cell able to give rise to tens of thousands of progeny. And although all of these progeny express the exact same T cell receptor, they vary in regards to the homing molecules that they express. And a single naive T cell upon activation will produce central memory T cells, effector memory T cells, and tissue-resident memory T cells, all specific to that antigen. So in a sense, when a naive T cell becomes activated, it will produce a complete set of memory T cells. And it turns out that activation of a naive T cell in a skin-draining lymph node is important, because the effector memory cells that are generated there are preferentially induced to express CLA and other chemokine receptors that facilitate their homing to the skin later on. And of course, another population will be induced to express CD62L and CCR7 and become central memory T cells. The effector memory T cells that are produced then exit that lymph node, they enter the circulation, and when they circulate through areas of inflamed skin, the vessels there will trap them and cause them to extravasate into the dermis. They follow chemotactic gradients to where the pathogen is, become activated, and facilitate the elimination of that pathogen. But some of these effector memory T cells then will remain in place in that area over long periods of time as skin-resident memory cells. And it is the expression of certain cell surface markers that define these cells as resident memory cells. For one, skin-resident memory T cells express CD69. And CD69 inhibits these cells from sensing sphingosine-1 phosphate gradients. And under normal circumstances, these gradients help guide T cells out of a peripheral tissue back into the lymph nodes in the blood. So CD69 blocks the ability of T cells to follow that gradient, and they become stuck in the skin. The lack of CCR7 expression does something similar. CCR7 is a chemokine receptor. It also senses gradients that help guide the T cells out of the peripheral tissue. So lack of expression of that marker means the T cell can't sense those gradients, and again, it supports their stationary nature in the skin. And finally, CD103 is a marker of resident memory T cells. It becomes expressed after the cells are extravasated in the dermis, and it seems to be right now simply a marker for resident memory T cells and not necessarily important for their functionality. Other important facts about the generation of skin-resident memory T cells is that an encounter with a pathogen at a specific site in the skin will lead to accumulation of numerous resident memory T cells specific to that antigen at the site of invasion, but it will also lead to the population of the entire skin surface with resident memory T cells specific to that antigen. So again, the immune system recognizes that, okay, if this pathogen tried to enter this site in the skin, there's probably no reason why it can't later on try to enter another site in the skin. And so it populates the entire barrier surface with cells that can recognize that pathogen should it try to invade a second time. And additionally, multiple sequential encounters with the same pathogen at different sites in the skin will lead to the accumulation of skin-resident memory T cells that recognize that pathogen. The more frequently a pathogen tries to invade the skin, the higher the number of resident memory T cells that will be present in that barrier. And this sequence of events plays out again and again over the lifetime of the organism, with the result being the accumulation of a very diverse population of skin-resident memory T cells that, in a sense, has been built to optimally defend the skin barrier in any one individual based on its experience. And these cells can be very potent in their ability to protect. There are studies that have shown that skin-resident memory cells, in the complete absence of any circulating T cells or antibody, can clear vaccinia challenge in the skin. Whereas on the other hand, mice who have central memory T cells specific to vaccinia, but completely lack skin-resident memory T cells, are unable to effectively clear vaccinia challenge. So let's talk about the role of resident memory T cells in skin disease and the implications for treatment. So as we discussed, resident memory T cells can be generated based on an extremely wide variety of antigens. And so this comes at the expense that occasionally you can generate a population of resident memory T cells inappropriately against an innocuous environmental antigen or even a self-antigen, and this can lead to disease. And there are a number of diseases that involve the skin where resident memory T cells are known to play a prominent role, and perhaps the best described, and certainly the first described, is the fixed drug eruption. Fixed drug eruption is an adverse drug reaction that's characterized by the development of one or more of these round to oval erythematous to violaceous patches. These can become bullous in nature. It can be a widespread eruption. And the interesting thing about this reaction is that even if a patient only has one lesion, every single time the patient is exposed to the inciting agent, that lesion will appear in the exact same anatomic location. This is a patient with AIDS who developed PJP pneumonia and was admitted right down the road from here at Jackson Memorial Hospital, and he developed a multiple fixed drug eruption to Bactrim. So this is not life-threatening, but it really made researchers curious because of this phenomenon that the inciting drug would make the lesion appear in the exact same anatomic location. And research has shown that, in fact, the pathogenic cell here is the CD8 positive skin-resident memory cell that cross-reacts with its particular drug antigen. And there are enough cells in that certain location that they can become activated and produce interferon alpha and generate these lesions. And there are a number of other diseases where resident memory T cells are well known to play a pathogenic role. Some of them are listed here. And we just want to take a few minutes to talk about two of them, psoriasis and cutaneous T-cell lymphoma. Psoriasis, as I'm sure all of you know, is a very common chronic immune-mediated skin disease. It affects 2 to 3% of the world's population. And plaque psoriasis is far and away the most common subtype, characterized by these very well-demarcated erythematous plaques with that thick scale. And it's well established that psoriasis is mediated mainly by skin-resident memory T cells, with Th17 cells being the major player, at least that's what is thought at this point in time. And these skin-resident memory T cells that are pathogenic in psoriasis may be generated against different antigens, autoantigens, pathogens, or environmental agents. And more insight into the fact that these were the main pathogenic cell in psoriasis came with studies where people tried to block E-selectin as a way to treat psoriasis. And E-selectin is expressed on post-capillary venules. And by blocking it, you inhibit the ability of T cells to leave the circulation and enter the skin. And it was found that blocking E-selectin actually had absolutely no impact at all on the treatment of psoriasis, which at the time was puzzling, but now we know that's because the cells that cause psoriasis are already living in the skin. They don't need to leave the circulation. The recurrence of treated or resolved psoriasis lesions will also occur by and large in the same anatomic locations when you remove medicines or when patients flare, similar to fixed drug reaction. And what this suggests is that although we may be able to affect the activity of the pathogenic resident memory T cells, we don't really seem to be affecting the fact that the pathogenic cells are there residing in the skin. And this has important implications for treatment. Over the past decade or so, we have seen a revolution in our ability to treat moderate to severe psoriasis. And we have many weapons available to us right now that can get most of our patients clear, if not almost clear, by targeting these well-known pro-inflammatory cytokines that are central to the pathogenesis of psoriasis. However, these do nothing, as far as we know, to affect the resident memory T cells that are causing the disease. And so when we take them away, by and large, patients are going to have recurrences. So in the future, it may be that if we can develop targeted therapies to actually destroy the pathogenic skin resident memory T cells causing psoriasis, we can generate more durable responses or even possibly cure this disease. And to that note, there are IL-23 inhibitors in development, and IL-23 is known to promote not only Th17 cell proliferation, but also to promote their survival. So it may be that by blocking IL-23, we do in fact impact the number of pathogenic skin resident memory T cells and maybe have a more durable response. So this remains to be seen. But this idea raises an important question. Has there ever been a disease where by targeting the pathogenic memory T cell, there has been efficacy in treatment? And the answer is yes. Cutaneous T-cell lymphomas are a heterogeneous group of T-cell lymphomas that are characterized by malignant T cells that express skin homing markers. So these malignant cells accumulate and proliferate in the skin. And there are two relatively common subtypes. Mycosis fungoides is the most common subtype, and Sézary syndrome is another relatively common subtype. Mycosis fungoides is characterized by these well-demarcated patches, plaques, and tumors that can occur anywhere on the skin surface. Whereas Sézary syndrome is characterized by the triad of erythroderma, so the patient has inflamed red skin covering at least 90% of the body surface area, generalized lymphadenopathy, and the presence of the malignant T-cell clone in the blood. Mycosis fungoides, by and large, is responsive to skin-directed therapies, especially early in the disease process. And like psoriasis and like fixed drug eruption, when patients flare or when they're taken off a medicine and the disease recurs, their patches and plaques and tumors tend to recur at the same anatomic locations. And in fact, research has shown that mycosis fungoides is a malignancy of a CD4 positive skin resident memory cells. These cells express CLA, CCR4, and CD69. One of the markers that we've seen is a marker for resident memory T cells. Sézary syndrome, on the other hand, is the leukemic form of CTCL, where the malignant T cells are found abundantly present in the blood, in the skin, causing erythroderma, and often in the lymph node. This has a very poor 5-year survival of 20 to 30%. These patients require multimodal therapy. The regimen I have had the most success using and still use is extracorporeal photopheresis with bexarotene, which is a retinoid approved for this disease, and interferon alpha injections 3 times a week. And here, unlike mycosis fungoides, the malignant T cell is a central memory T cell. And these cells actually display both skin homing markers, as well as strong expression of central memory cell markers. So these cells traffic between the blood and the skin, which we know that is where they're found. Alemtuzumab is an anti-CD52 monoclonal antibody. CD52 is expressed on all lymphocytes. Alemtuzumab can deplete CD52 positive cells in the blood. And studies have shown that it is quite effective at depleting the malignant clone in patients who have Sézary syndrome. And it does this in the blood via antibody-dependent cell-mediated cytotoxicity that requires neutrophils and some other cells like natural killer cells. And it has recently been shown to have pretty high efficacy, upwards of 50%, in patients with Sézary syndrome for inducing a complete remission. That is not the case with Mycosis Fungoides. As we've seen, is a disease that is mediated by a skin-resident memory cell. So alemtuzumab will bind those malignant cells in the skin, but it cannot kill them because the neutrophils and the natural killer cells that are required for antibody-dependent cell-mediated cytotoxicity are scarcely present in the skin. So it has no effect in patients with Mycosis Fungoides. Here's an erythrodermic Sézary patient given alemtuzumab, almost clear. On the other hand, a patient with Mycosis Fungoides who's given alemtuzumab has essentially no response whatsoever. So let's talk about resident memory T cells as a general human barrier defense strategy in their role potentially in numerous chronic diseases and for improving vaccination. You may have guessed, although we've been focusing on the skin, that in fact tissue-resident memory T cells are abundant in all barrier epithelial tissues, including the gut, the lungs, and the urogenital epithelium. And they've also been shown to be present in non-barrier tissues, including synovioenthesial tissue. And in fact, Dr. Husney showed you that very nice diagram of the immunopathogenesis of psoriatic arthritis and mentioned resident T cells in enthesial areas. Also been shown to be present in the kidney and the brain. And as in the skin, it appears that the location of the draining lymph node where the naive T cell is activated is what is critical in determining where resident memory T cells will eventually live. For example, if a naive T cell is activated in the gut, then it will induce the production predominantly of gut-homing resident memory T cells. And the result then for the host is that they accumulate a very diverse but also largely non-overlapping population of resident memory T cells in each barrier tissues. And each specific population is predominantly composed of memory T cells for antigens that have been known to try to invade that particular epithelial barrier system. Again, a very elegant way to build an armed forces unit for the host. We talked earlier that a naive T cell upon activation will build, in a sense, a complete set of memory T cells, tissue-resident memory cells, effector memory cells, and central memory cells. It turns out that the central memory cells, after they are made, enter the circulation, and occasionally they will enter other lymph node basins, expand, and can differentiate to express homing markers to other barrier epithelial tissues. So a skin invasion or immunization will lead not only to abundant accumulation of resident memory T cells specific for that pathogen in the skin, but also other barrier epithelial surfaces will be populated with some of those cells. So the body also recognizes that if something can invade the skin, then maybe it'll try to invade the lung, and it will put a few soldiers there to recognize that pathogen in the lung. And studies have also shown that those cells can be highly effective. Lung resident memory T cells that were generated by skin vaccinia scarification have been found to partially protect mice from an otherwise lethal pulmonary challenge of vaccinia in the complete absence of circulating T cells or antibodies. So over the past few years, there has been great speculation that there are probably many autoimmune or immune-mediated diseases where a tissue-resident memory T cell plays a prominent, if not the prominent role in the pathogenesis. And some of those diseases are mentioned here in each of these different organs. And again, a lot of this right now is speculation. There is not great experimental evidence, but I suspect that over the next few years, all of you, regardless of your specialty, will be learning about resident memory T cells for the diseases that you treat and their role. And finally, I just want to close with a short discussion about resident memory T cells and vaccination. As all of you know, viruses tend to display tissue tropism. For example, influenza is specific for the lung. And currently, it is the titer of neutralizing antibodies generated by the vaccine that is considered a proxy for its efficacy. However, for a virus, when it infects a cell and takes over that cell's machinery to produce more virus, we know it's largely insensitive to extracellular antibody. Whereas on the other hand, those infected cells are known to eventually express cell surface viral peptides on the surface that make them excellent targets for CD8 positive tissue resident memory cells. And so it may be that exposing an antigen to an epithelial surface for vaccination, as opposed to an intramuscular injection, could be a much more effective vaccination strategy. Because such a strategy, as we've just discussed, would be expected to generate a population of tissue-resident memory cells specific for that antigen at the appropriate epithelial barrier surface that you want to protect. And there are some animal models that have suggested, and studies in these animal models suggesting that this in fact can be an excellent strategy for vaccination. So there is a lot of future research that obviously needs to be done concerning tissue-resident memory T cells. Currently, there is a lot of research concerning, in more detail, what are the cell signaling interactions that maintain these cells in their resident tissues. Of course, we're just touching the surface of the role of tissue-resident memory T cells in a wide variety of autoimmune and immune-mediated diseases. And with time, we can better understand the implications in terms of treating these diseases. And although vaccination strategies to produce tissue-resident memory T cells sound great on paper, we have to learn, are they really feasible and practical in real life? So in summary, skin-resident memory T cells are strategically positioned in the skin, and there are resident memory T cells in all other epithelial barriers that are able to provide very rapid immunity against secondary pathogen challenge. The role of skin-resident memory T cells is known in several skin diseases and has important implications for treatment. And our future understanding of these cells may lead to better vaccination strategies as well as treatments for many other immune-mediated diseases. Thank you for your attention.